Okay. Can I ask, when you move your patients to Leicester, how long will they on Leicester? Because what you're saying in the 12 hours in A&E, it's an hour a sick day. How long will they stay in Leicester?
Yes, I don't have figures on that to know how long they stay in an episode, but it's a totally different environment. So they're sat in chairs, it's not in the pressure of the emergency department. And part of the problem with the emergency department crowding is you've got really sick people who aren't getting the care or the environment that they need to receive care in because there's so many patients in the area. So I expect that with, by allowing these patients to go to a separate area, everyone benefits. It is a short stay area, so they will be, the idea, they really want the low-risk patients. It's a problem for the patient who has to be admitted from SO because they get a lower priority than the emergency department patients. So that's why the care testing is really helpful, because you can really accurately select a low-risk cohort much better than you can just from a gut feeling at triage.
Any other similar problems?
I actually have some questions, one for each of you, but so maybe I'll give you your question first, Rick, and maybe your question that's also, and then you can think about it. So the question for you is around, Sarah, we talked a bit about point of care testing in stroke, and you think we tested for something you don't already. I just wondered in terms of, we're struggling in terms of cost and how we then get implemented. I wonder how thinking about changing pathways, changing processes within MFT. Obviously, A&E has a huge lever in terms of, impacts, and everyone's interested in reducing things. I just wondered how difficult that was. And maybe because you're doing something new, effectively, I suppose you're taking tests out of labs and just putting them in a different location. So my question was around change and how easy that would be. And our question for you is, I'm conscious in the point of care testing, there is some stuff being developed in stroke around diagnosing. I just wondered if you would have to scale up point of care testing for more than one condition, how challenging that might be, whether ambulance service needs to think about, having fridges and the lack of ambulances and things like that. So that was my question for you.
Yeah, great. So, it's really difficult. We've done this before with blood pregnancy testing and point of care. And we were taking a really long time to get the lab results back for pregnancy tests, like 2.5 hours, because we were running duplicates, especially if you were positive. And that's a rate limiting step for the patients, because you can't do imaging. It depends which specialty you might send the patient to, depending on the result. So you think again that would be a no-brainer. But when we did that implementation project, there was very little uptake at the start. And so we were able to understand a little bit about it and what was driving that. Some of it was the support workers saw it as an extra task. It was easy to send the test up to the lab, just do what they always do. Whereas doing a point of care test, you've got to go and get the machine and wait for the result and hand it to someone. It was much harder. So we had to get buy-in from them to understand why it's important. We had to make it easier for them. So little things like having a bag with all the equipment they needed for a point of care test, all ready for them, right where they do the blood test, whereas they'd have to go and get a blue tray and all the equipment to do a lab test, making it easier for people to do the point of care test. And then changing the care pathway was a really difficult bit. One of the doctors even said to me, and I said, the idea was, well, if you've got a patient with a negative test, you go home, can we see them a little earlier so that they can just go and remove them from the queue? And someone found that ethically challenging. We're used to seeing the high acuity patients first. So when you've got to wait, you see the sickest people first, and the less sick people can wait. So that would mean that, a negative pregnancy test means you identify someone who's going to wait longer. And that can happen with troponin too. You say, oh, it's fine, and they can just wait because they're not sick. And that's what we've got to challenge, because everyone benefits if the low-risk patients go home quicker. The low-risk patients benefit from not being in a hospital, but the higher-risk patients also benefit from being in a less crowded ED, where there's less distraction for the staff and they get more care. So those are the things that I think we've got to address.
So, going to your question, so it would be great if the ambulances had that little fridge. I've looked at it. I remember when I was trying to solve sort of the cold chain problem, I found a company in Italy that would do a basically refrigerated drawer. And I did message them, but unfortunately I'm not Italian, so I think they just ignored me. So having a fridge in the ambulance would be brilliant, because not only could we have cold chain maintained, there's other medications that we can use that would require a cold chain as well, which will potentially be for the better. There's loads of things that are out there. Point of care is coming into itself. There's, the Abbott test itself will do 10, 12 tests, things like that we can use potentially to do a variety of tests on patients in pre-hospital setting. But my challenge is always is, how much should we be doing as paramedics? So you mentioned the stroke point of care test. Is it an LV1 that tests for large occlusive strokes? That's I think it's a dead easy one because it's like a lateral flow test. But as I said before, in Manchester, we're a stone's throw from the HAS use, or at least a hospital with a stroke unit within it. So again, depending on how long those tests take, it's that balance between I'm going to do this test because it'll take me 20 minutes, or I spend that 20 minutes taking the person to the place where all the kit is, the doctors are. So while I believe there is a place for point of care testing, I'm looking, the next stage for me is to look at what we can bring in as an ambulance service and what would benefit the patient. So I looked at 2024 data for presentations that we routinely take to hospital, because within that will be patients who will come in, they'll have an assessment, they'll have a test, and they'll go home. So we have a band of advanced paramedics that could potentially do this interpretation. My concern with that is the rafter tests that are available for point of care, how much of it should we know about or do we need to know about? Where they cross over and where they mix. So if I go to someone who's got a breathing problem and I find that they've got a raised liver, a raised kidney function, I've found something I wasn't looking for. Am I going to then admit that patient for something that might be just an incidental finding? So everything that we do pre-hospital, for me, needs to be a strict pathway to reporting. Is easy because, in the sense of, we create a pathway of we're not changing how we deal with these patients, but we're providing more information to the hospitals. And then just to touch on cost, we did a cost-benefit analysis for this pilot, and we found that the hospital saved around £1.1 million. The ambulance service lost 110 grand, and then the ambulance time was around 700 hours. It was a lot. So imagine how many ambulances we would need to get that time back and the investment we would need. And for me, I would ring the hospital and just go, you can give us that money, but they'll want to make that saving. So it's a difficult thing to say, where does the funding come from within that pathway?